Welcome to Global Dispatches, a podcast about foreign policy and world affairs. I'm your host, Mark Leon Goldberg, editor of UN Dispatch. And in this show, we discuss topical global issues, have conversations with foreign affairs thought leaders and newsmakers, and give you the context you need to understand the world today. Go to globaldispatchespodcast.com to learn more. And now on with the show. Among the many barriers to quality healthcare in the developing world is the high cost of medicine. This is due in part to frequent disruptions in the supply chain. Customers who visit a pharmacy to purchase medicine can't be guaranteed that the medicine will be something they can afford, or even if the medicine will be there at all. My guest today, Gregory Roxon, is a social entrepreneur who has figured out a way to make medicine in several African countries more affordable and access to that medicine more reliable. He is the co-founder of the company M Pharma, which, as he explains, essentially manages key nodes of the supply chain of drugs for independent pharmacies. Unlike here in the United States, where big pharmacy chains are ubiquitous, in places M Pharma operates, small and independent pharmacies serve the vast majority of the population. M Pharma essentially manages the drug supply chain of the participating pharmacy and assumes the financial risks if drugs are over or understocked, sharply driving down the costs. M Pharma has developed what I think is an absolutely fascinating business model, and it's already revolutionizing access to medicine in 5 African countries and is poised for further expansion. This episode is part of a content partnership with the Skoll Foundation to showcase the work of the 2019 recipients of the Skoll Award for Social Entrepreneurship. M Pharma is one of those recipients. The Skoll Awards distinguish transformative leaders whose organizations disrupt the status quo, drive sustainable large-scale change, and are poised to create an even greater impact on the world. Recipients receive $1.5 million in core support investments to scale up their work. And now here is my conversation with Gregory Roxon, co-founder of M Pharma. Just to kick off, can you kind of describe why are drug prices so abnormally high in many of the countries in which you work?
So I think there are 2 reasons for that. One is a failure of government policy. So unlike in Europe, where governments regulate drug prices, and most governments set a ceiling on drug prices, the African pharmaceutical market, at least in English-speaking most African countries, particularly Anglophone Africa, is unregulated, similar to the United States. So any pharmacy can charge whatever price they want to charge. Any drug company can charge whatever they want to charge for any product. And it leads to the second problem, which is that pricing becomes a volume-based arrangement. So the more you can buy, the less you pay, which creates a lot of disadvantage for pharmacies in the countries that we work in, who for the most part are small independent pharmacies that do not traditionally buy large volumes to be able to negotiate better pricing from the distributors and manufacturers.
So basically, most pharmacies in the countries in which you work are, what we would call mom and pop shops, just small, independently owned pharmacies that don't have much control over the value chain.
Yes.
And so, from like a consumer perspective, say I'm like a diabetic guy in Ghana. Like, what are my options? Like, how do I go about purchasing my medicines, getting my insulin?
Well, you really have 3 options, but one is more likely. One is that, at least in Ghana, there's the National Health Insurance System, which is the government's insurance program, which covers about 50% of the population and covers a number of drugs. However, the government is notorious for not reimbursing claims, so most providers don't actually accept the government insurance plan for drug dispensation. So then that leaves you to hopefully, if you work for a corporate that offers private health insurance, then you can at least have your drugs paid for by the private health insurer. But private health insurance is limited to big companies. So, for example, in Ghana, the total private insurance market is less than 300,000 enrollees for a country of 27 million people. So overwhelmingly, most people have to pay out of pocket for their medication. So if you are a diabetic patient that needs to buy insulin, you either walk to a pharmacy and depending on how much money you have, you can pay for it, or you go for a cheaper option if they're available. And if not, your other option is to skip your medicine.
And basically the prices aren't standardized, as you said. So, two pharmacies in the same city could be selling these medicines for wildly different prices.
Exactly.
And so how did you come to start M Pharma as a way to sort of standardize drug prices? Where did you get your idea to start M Pharma?
Well, so I would say it was an evolution of ideas. When we began M Pharma, we were focused on building electronic prescription systems so that we can begin to collect data on medicine use in the countries that we work in. And that's how we began. And by collecting this data, we began to really understand the magnitude of stockouts in these hospitals and pharmacies that we're working in. So looking at that, we realized that a lot of these pharmacies is either owned by a pharmacist who employs a pharmacy technician, and these people are trained in the clinical services and patient care, but they are not trained as supply chain experts or managers. That is not part of the curriculum if you go to pharmacy school, right? So a lot of times these pharmacies owners buy based on intuition. They see, someone walked in to buy something, they realize that they ran out of stock, and then they rush to place an order to restock their shelf space, which also means that they're doing a lot of emergency orders in low volumes, which means they cannot get better pricing, as I mentioned earlier. But the good thing about the pharmacy business is also the fact that almost all pharmacies stock the same drugs, right? The Galvox in pharmacy A is the same Galvox in pharmacy B, right? Because medicines are pretty much commoditized. So we realized that what if we could actually build a model whereby instead of each pharmacy having to be its own procurement manager, we could actually centralize the procurement system across all these pharmacies. So in a way, M Pharma becomes the procurement agent on behalf of each of these pharmacies. But going beyond just procuring the drugs, which is just one problem that the pharmacies face, we also realized that because we had built data systems that allowed us to track the movement of drugs across these pharmacies, we could actually also take the responsibility on ourselves on managing the inventory. So we built a consignment stock model whereby we source, procure, and then provide these drugs at no cost to the pharmacies that join the network, right? So for the pharmacy, it's like they given their shelf space to M Pharma at no cost to manage. Mm-hmm. We provide them inventory, and then all they have to do is focus on patient care because they only pay M Pharma for what they dispense, not what we put on their shelf.
Oh, so they're not so if there's like expired medicines, they don't have to assume the risk
Exactly.
of leaving those on their shelves to expire. You assume that risk, and you're
Exactly.
able to reduce the chances that such medicines will expire by using your kind of big data and data collection to analyze trends in medicine consumption, I assume.
Yes, because I mean, fundamentally, expiry management is an issue of it's a data management problem, right? When you think of mPharma's model, what it means is that every pharmacy that joins the network is a mini warehouse for mPharma, right? So if we stock up a pharmacy, for example, and due to seasonality, we realize that inventory is now moving, right? But then another pharmacy on the network needs that inventory. We can always go and remove that inventory and reallocate it to another pharmacy,
Hmm.
right? So we are always constantly rebalancing stock across the network.
Can I ask, when you're building out this data system, perhaps early in M Pharma and even today, like, are there any trends in the data around medicine procurement and consumption that perhaps like surprised you?
Yes. We recently did a study on antibiotic use, which is obviously a very prevalent problem in the global health community. And we were trying to understand, antibiotic use across Ghana, Zambia, Nigeria, and Zimbabwe. And it was very shocking, the type of test and conditions that pharmacies were dispensing antibiotics for, which was very different across all the different markets that we worked in. I think also one thing that was very interesting for us when we began our work was just to understand the number of independent suppliers a single pharmacy works with to stock up their pharmacy. It was just mind blowing because now we had to begin to consolidate all those supplier networks into a single entity that we could now manage on behalf of all these pharmacies that were joining our network.
So if you're just an independent mom and pop sort of pharmacy, you have to work with like 10 different drug suppliers in order to keep your medicines on your shelf.
Exactly.
Hmm. And so as M Pharma evolved and began to use this data, what sort of outcomes have you been seeing from like a patient perspective? If you're, you're now operational, I think in 4 countries, is that right?
And we just entered Kenya through an acquisition of the second biggest pharmacy chain in the country.
Ah, okay. So now you're acquiring chains as well, and I have to imagine that in Kenya you're also acquiring and partnering with these smaller independent pharmacies.
That's the plan. So we
Hmm.
intend to use the pharmacy chain that we've acquired as the vehicle to provide supply chain efficiency to other mom and pop pharmacies.
Okay, so if you've sort of described how you support pharmacists and the pharmacy industry. If you're a patient, how does one interact with M Pharma?
Sure. So, within M Pharma, we have different solutions. So, the fundamental solution, which is the backbone of our work, is what I explained to you, our vendor managed inventory service, where we just manage the back end supply chain infrastructure for these pharmacies. So, as a patient, all you realize is that your pharmacy in your neighborhood now always has the drugs they need available. You never actually know mPharma, right? You just know that the drugs are there, right? Maybe the pharmacy used to struggle in the past, but now that they've joined mPharma's network, you go there and the drugs are always there because we are now taking on the responsibility for restocking.
And I have to
But
imagine, sorry to interrupt, that you operate almost as like a social franchise where there's like branding around these pharmacies so that patients sort of know that this is like a good pharmacy to use and that they will have the medicine.
So that leads to the second solution that we
Ah.
just built. So with our VMI network, we don't have any exterior branding. Um, it is a challenge we've just focused on just being a supply chain manager for all these mom and pop pharmacies. However, as you rightly mentioned, we saw another opportunity to begin to leverage the supply chain excellence that we're building to begin to do conversion franchising, which is M Pharma now beginning to rebrand some of these mom and pop pharmacies that we were supporting through supply chain work, because we realized that beyond just actually providing the inventory, we had a number of mom and pop pharmacies, particularly in low income areas, that wanted us to work with them, but they also had very poor infrastructure, right? So the walls are dirty, the ceilings are leak, and when you walk in as a patient, you really don't have a lot of confidence in that particular pharmacy, right? So we realized that if we were to help them increase their patient foot traffic, we had to not only provide them with inventory, we had to think about how we could support them to refurbish their outlets. Now, all of these pharmacies did not have the working capital to be able to refurbish. So we built a program called Quality RX, which is a conversion franchise model where we go into the pharmacy and then we actually do the refurbishment at no cost to the pharmacy owner. And then once we do the refurbishment, we sub-brand that pharmacy with the Quality RX brand. And we now also begin to manage their inventory for them. And they only have to repay that refurbishment cost through a profit share arrangement with M Pharma.
So, it sounds like M Pharma is really scalable, that, you're able to enter these new markets, transform the both the way in which individuals interact with pharmacies and get their medicines and reduce the prices. It seems, I can see all the sort of the social good that is achieved through expanding M Pharma. What are some of the barriers that you've experienced in reaching new markets?
I think one of the big issues for us has been that the M Pharma model requires a behavioral change, right? Traditionally, the drug supply chain has been a very transactional relationship, right? So a distributor just focuses on selling to the pharmacy. They don't care about whether the pharmacy needs the products that they are selling to them. They just want to make a sale, right? So you see distributors, trying to convince pharmacies to buy a lot to get discounts, even when the pharmacy knows that they would not be able to actually sell those products, since a lot of patients would not come in before the products expire. Also, so when we came in and we said, you know what, let's transform this relationship. Instead of thinking about M Pharma as a distributor, think about M Pharma as a partner in your business. We will take on the inventory liability, and you can just focus on the front shop and offering clinical service and clinical advice to patients. And that required a big mindset, because in the beginning, it sounded too good to be true for these pharmacies. Mm-hmm. And they always wondered, why is M Pharma doing this? Like, why? What's in for us? And it took a while to convince them that actually we were doing this because it also made a business case for us to do this. Beyond that, also, supply chain and procurement is known to be riddled with bribery and corruption. A lot of times, procurement managers, get kickbacks from drug suppliers in order for them to continue to buy from them and over order, right? So when M Pharma came in, one of the unintended consequences of our work is that we began to actually provide drug variance reports to the managers of these pharmacies, right? Because we own the inventory. We know exactly how much inventory we put in the pharmacy. We know from our data how much was sold. And we also do physical stock count every month across our entire network. And with these 3 data sets, we are able to actually have a complete view on what is actually happening with the inventory in the pharmacy. And with that, we began actually providing variance reports, which was the first time a lot of finance managers in the hospitals we were working with actually began to understand the true state of medicine inventory in their businesses. And
so they could look at your report, see how much cheaper your drug prices were compared to other markets or other pharmacies in which there was perhaps kickbacks involved and corruption involved that involved sort of unnecessary markups of the prices.
Yes, and also
you must have made some enemies. I must think.
Yeah, and sometimes people also buy inventory, right, in the name of their pharmacy, but then they actually divest the inventory from the pharmacy to their own private business or resell it to other people, right? But for the first time, we could actually provide the actual variance reports in these businesses. And, people didn't like that because we took away one of the most powerful power that these pharmacists had, which was the procurement power. And that created a lot of enemies in the beginning and still does.
So let me maybe conclude by asking you sort of where we began. You kicked off by explaining that at the root of the high drug prices is one factor is the fact that governments don't have ceilings on certain prices. It's sort of like what we have in the United States here. What sort of policies could governments implement or could governments adopt that would both enhance the kind of work you do and also more generally lower drug prices and ensure that there aren't the kind of stockouts that sometimes plague hospitals in areas where you work?
Yeah, that's a great question. To be honest, and this may sound a bit controversial, but I think government should not be in the business of supply chain management. We've seen the public sector riddled with a lot of corruption and bribery. In most African countries, governments have shown that they are wholly inadequate set up to be able to even manage inventory stocking in government hospitals. That is why several government hospitals have a lot of stockouts, and most often people have to go to the private sector to purchase their medication. Actually, I think one of the best things governments can do is to use the M Pharma model, whereby a government says we will outsource our central medical store to a company like M Pharma to manage. And that company will be responsible for financing all the drug inventory needs in the country, will then be responsible for managing the inventory in the public hospitals, and the government only pays for outcomes, right? Because the government only pays when drugs are dispensed to patients that go to public hospitals. Now, what this means for governments is that one, the governments do not now need to hold money in advance to procure drugs, right? Because all they are doing is paying for outcomes. Two, it brings more of a financial, it aligns financial incentives between the government and the company, since the government now is able to remove the procurement power from its own system and removes the incentives people have to put up tenders that are inflated, because the government is no longer in the business of offering tenders. I think this shift, whilst controversial, will be one of the biggest changes governments can do to actually improve the issue of drug affordability and availability in the public healthcare sector, and also remove the budget constraints that governments currently have in order to buy drugs in advance for the public healthcare system.
Well, Gregory, this is fascinating and brilliant, and I'm really excited to see where M Pharma goes next. Thank you so much for your time.
Thank you.
All right. Thank you all for listening. Thank you to Gregory and to the Skoll Foundation for supporting this episode. The content from this episode, I think, has been just great content in the wheelhouse of Global Dispatches podcast. So I'm very delighted for this content partnership. We have 2 more episodes coming up, so stay tuned. They'll be published in the next couple of weeks. And I should say I'm recording this little outro right now from Oxford. where the Skull Forum just finished, and it was absolutely fascinating and sort of like in the spirit of the kind of amazing collaborations that I've seen happening around the Skull Forum. If you're ever interested in getting in touch with anyone I interview, then you're in a position to act on some of the ideas or policies that the people that I interview have recommended, let me know. I'm happy to try and facilitate those introductions. I try to, again, inspired by this Skull Forum, I use this podcast to try to make a difference in the world, and the people who listen to this podcast, you are the ones who can make a difference. So, we can all make a difference, but some of you sort of try to make a difference professionally every day. And if you want to get in touch with anyone I interview, just let me know. All right, thank you, and we'll see you later. Bye.